Day space ventilation is the amount of volume of gas that does not get involved in gas exchange. Okay. Now, what do we mean by gas exchange? Well, you know, the oxygen that we breathe in, we send it down to the tissues. The hemoglobin transports the oxygen down to the tissues. Down inside the tissues, the oxygen is used for metabolism. So it kind of goes like this. So you take your glucose plus oxygen inside the tissues, you're going to produce ATP, heat, CO2. That's what we do every day. We're doing that as we're sitting here now. So you take glucose plus the oxygen that we put in inside the tissues, metabolism takes place. You produce ATP, adenosine triphosphate. That's a form of energy. So that's what gives you the strength, the muscular activity, the strength to move your muscles. And then you produce body heat. Now the heat is used to maintain body temperature. Okay? And now the metabolism also yields CO2. Now CO2 is a byproduct of metabolism. We have to excel it out. But unfortunately, we can't excel all of it out. Okay, some of the CO2 will be dissolved in the blood. That's how you get your partial pressure of CO2, which is 35 to 45. That's normal. So anytime you have it more than 45, it means that your body is not clearing enough CO2. Okay? So what's going on down here is the CO2 comes around to the lungs, okay? Coming from the blood, from tissue, comes around to the lungs. And now the CO2 will diffuse from the blood into the lungs, because the amount of CO2 inside the blood is greater than the CO2 inside the lungs. So diffusion gradient is that way, okay? And now the oxygen that was inspired from the outside comes down here because we have more oxygen here than inside the blood. The oxygen will go into the blood. So as oxygen is going inside the blood, CO2 is leaving the blood. That's called gas exchange. Gas exchange. Okay? So when we talk about day space, what we're talking about is the volume of gas that doesn't get involved in this volume here. Okay, so if you look here, all the way up here, when you breathe in, the air comes down, gets down here, you still have some air up here. So this air up here does not get involved in gas exchange. Gas exchange takes place down here. So this is like wasted ventilation, wasted air, if you want to call it that. Wasted air, wasted ventilation. We don't need it. Okay, all we need is the volume that actually went down here. Okay, so this is dead space. The volume of gas that does not get involved in gas exchange. Another way to define that is that you can say that it is ventilation in excess of perfusion. Ventilation in excess of perfusion. In other words, you're ventilating, but you're not perfusing. Okay? Any questions about that? Types of day space. We have an atomic day space. Okay? Now, an atomic day space is the volume of gas that fills the nose, the mouth, the breathing, all the way down here to the terminal bronchus. Okay? Yeah, that's an atomic day space. volume in your nose, your mouth, your trachea, all the way down to the terminal bronchus, the last branch of the bronchus that gives rise to the alveolus is the terminal bronchus. Okay, so normal anatomic dead space is 1 milliliter per pound of a patient's ideal body weight. You all remember how to calculate ideal body weight? 50 plus 2 times at less than 60 inches. Okay, so you take that, you multiply it by 2. Let's do 1. So let's say that I'm 65 inches tall. So I'm going to go 50 plus 2 times height less than, it's greater than 60 inches. So I go 50 kg plus 2. I'm 65 inches greater than 60. So that would be 2 times 5, that's 10. So I'm 60 kg. Yeah. That's in kg. So if I want to convert it to pounds, I will multiply by 2.2. Because you have 2.2 pounds make 1 kg. Okay? So if I'm not intubated, okay, then my normal anatomic dead space will be 1 milliliter per pound of ideal body weight. If I'm weighing 150 pounds, then my anatomic dead space will be 150 milliliter if I'm not intubated. If I'm weighing 250 pounds, God forbid I weigh that much, then my anatomic dead space will be 250 milliliter if I'm not intubated. Okay? And what we mean by that is the amount of air, okay, from here to down here. Okay, it's based on your height. Okay, lung volumes are measured based on height, not necessarily weight. Okay? All right. But if a patient is intubated, that's different. Okay, because now think about this. You know, ET tube now, ET tube comes down this way like that. Okay, so actually it's supposed to go down here. But now if you look at the ET tube, when you breathe in, the air goes in here to the ET tube. Now the diameter of the ET tube is way smaller than the diameter of your trachea. So it will not hold up a lot of volume. Okay, so that's why the dead space will be smaller if you are intubated. Okay? So if you're intubated, it will be 1 milliliter per kg of ideal body weight. Like here, if I'm intubated now, I weigh 60 kg, my dead space will be 60 milliliter. Because the ET tube cuts the anatomic dead space into half. It will not contain a whole lot of air. Okay? The longer the airway, the more the anatomic dead space. The shorter the airway, the smaller the anatomic dead space. So if you took 2 patients, one is intubated, one is straight, the patient who is straight will have less anatomic dead space because the tracheostomy tube is just this long. It will not contain a whole lot of volume. But the ET tube is longer, okay? It will contain a whole lot of volume. So that's sometimes, what they do sometimes in the ICU. If a doctor is having difficulty weaning somebody who is intubated and they have been on mechanical ventilation for a while, the doctor can go ahead and trach them, okay? Because once you trach the patient weans faster, okay? You reduce their space. Okay, so this is what you're looking at here. Okay, so now look now. When you exhale out, when you breathe in and exhale out, guess what? The first volume that will leave your lungs will be this ones out here. This volume here, which is low in CO2 now, will first of all get out of your lungs. And then you have this one here coming up now with high CO2 and filling up here. When you breathe in again, the fresh air comes in and pushes that air that is slightly higher in CO2 back down into your lungs. So it's like the more dead space that you have, the more CO2 that you're going to have. Okay? Any questions about that? So dead space increases CO2 because you're rebreathing CO2. So another name for dead space is volume rebreathe. Volume rebreathe. Okay? All right. Okay, so we have another type of dead space. This is inside the alveolus. Alveolar dead space. Okay, so alveolar dead space is, let's say that this is the alveolus, and this is the pulmonary capillaries, the blood vessels around the alveolus. Okay? And now the air is coming in. Let's say you have a clot here, pulmonary embolism. You have a clot here. So now blood flows around here, but it cannot perfuse this area because of the clot. So this whole area is not getting enough perfusion because of the clot here. But the air is still coming in. So alveolar dead space is the volume of air that fills an area of the alveolus that is not being perfused. So that's what we say, ventilation in excess of perfusion. The patient is still ventilating, but now perfusion is diminished because this area is not getting perfusion. Ventilation in excess of perfusion. The amount of volume that fills area of an alveolus that is not being perfused. Now, alveolar dead space is very small in value. It is actually insignificant. It doesn't cause any problem to your ventilation. It doesn't cause your CO2 to rise significantly, because we know now that dead space includes CO2. Unless you have a dead space problem on board, like pulmonary embolism. Pulmonary embolism is dead space disease. It will cause your alveolar dead space to rise. We have a few others like pulmonary hypertension. Okay? I'll tell you about those in a minute. All right, so the next type of dead space is physiologic dead space. Physiologic dead space. Now, physiologic dead space is the sum of the anatomic dead space and alveolar dead space. The sum, when you add those two together. But now, depending on which book that you're reading, like your mechanical ventilation book, Sue Pilgrim. Sue Pilgrim was my instructor in school, that textbook. She was my instructor, yeah. All right, so if you read that Mr. Pilgrim's, Mrs. Pilgrim's book, this is the way that she defined it. But now you may read another book like your review book. That guy says that physiologic dead space is equal to alveolar dead space. Okay? No, excuse me. Physiologic dead space is equal to anatomic dead space. Because the alveolar dead space is insignificant, it's very small that it doesn't even count. Okay? So some of them will say that physiologic dead space is equal to anatomic dead space. And then some of them will say, well, physiologic dead space is the sum of the anatomic dead space plus the alveolar dead space. Either way you go, you'll be fine because the alveolar dead space is very, very small. It doesn't cause any problems. Okay? Now, we have a formula to calculate physiologic dead space. Calco minus pico over calco. Do you go over that? Everything is CO2. Arterial CO2 minus external CO2 divided by arterial CO2. It doesn't make sense, but it works. Okay? All right, so now we have mechanical dead space. Mechanical dead space is the amount of volume of air between the patient and the ventilator circuit. Why? So it's like this. Here's the ventilator circuit. Here's the inspiratory limb. And then we connect the ballast suction catheter here before it hooks up to the ET tube. And then here's the patient. Like that. So this is mechanical dead space. That suction catheter here contains volume. So it's the amount of volume inside that little circuit, 50 milliliter length. Okay? Plus other things that you may hook up here. Remember, we can hook up HME between the patient and the ventilator circuit. We can hook up the CO2 detector, capnography. So three things that we can hook up here. Okay, now, in most cases, depending on who made the ballast suction catheter, it will produce about 80 milliliter of dead space. That ballast suction catheter, that's the whole thing. And then if I add my HME there, instead of using the heated humidifier, HME, most of them will give about 20 milliliter. But the HME is just this small, right? And then we can also hook up CO2 detector between the wire and the patient. Those are about 10 milliliter. Very small, like that. So now, when you end up these three here, you get like 110. Okay, so if I have those three things hooked up between the patient wire and the patient, I have 110 milliliter of volume. So what happens then is that the patient breathes in like that. You go down to the patient, okay? And then the patient exhales out. Now, the air up here comes out first, which is low in CO2 now. Because gas exchange is down here. That's where the CO2 is coming up. So this gas here comes out first before the one down here begins to come up. And then fuels here. The patient is done exhaling out now. During the next inspiration, this fresh air comes down here and pushes this volume here back down into the patient before the fresh air comes in. Are you getting me? So what we're saying here is that normal mechanical dead space is 150 milliliter. As long as you don't have more than 150 milliliter volume between the wire and the patient, your CO2 will not rise significantly. You are not going to rebreathe a lot of CO2 to make a difference in your arterial CO2. Yeah?
I think I know the reason why, but just in case, why doesn't the inspiratory and expiratory limb count as dead space?
Say that again?
I think I know the reason why, but just in case I'm
now
wrong.
Ask me the question. We're going to take off the mask next week.
Why doesn't the inspiratory and expiratory limbs count as mechanical dead space?
Oh, okay, thank you. Okay, so it's because of rebreathing. Dead space is volume rebreathe, okay? Because now, see, when you exhale out, it doesn't go this way, it goes that way. There is an expiratory valve, an inspiratory valve on the ventilator. So the ventilator, when you look at it, what happens is that when you get ready to breathe in, the expiratory valve inside the ventilator will close so that the patient doesn't breathe out. So the air can only go one way. There's resistance on this side, air cannot go that way. When the patient begins to exhale out, the inspiratory valve closes so that when the air is coming out, it can't go that way. It puts resistance on it, so it can only go the other way.
Okay.
Okay? So the only thing you can rebreathe is what is down here, but not
Okay.
here or here.
Thank
Okay?
you, yeah.
Does that help?
Yeah, thank you.
Okay, very well. All right, so what we say is normal mechanical dead space is 150 milliliter or less. Basically, what that means is that as long as you don't have more than 150 milliliter of volume between the patient and the patient, okay, your CO2 will not rise significantly. You're not going to rebreathe a whole lot of CO2 to make a difference in your arterial CO2. That's what we're saying. Okay? Because now, think about this. When you want to give a breathing treatment to your patient, aerosol therapy on the ventilator, if you hook it up here, that's one more length, about 50 milliliter. If you hook up your breathing treatment between the patient Y and the patient, you have increased dead space. Have you ever given a breathing treatment to a patient who is on the ventilator? Aerosol, where do you hook it?
Most of them are hooked up by the inspiratory limb, like on the other
Very
side.
good, inspiratory limb, that's why you're going to hook it up here. See? But if you hook it up here, then you lengthen the amount of volume that the patient can breathe. That's the reason why we do that. Okay? But I'll tell you one thing though, just you gotta be careful on the exam. Okay? If you have any kind of dead space at all, mechanical dead space, it will cause your CO2 to rise. But the question is, by how much will your CO2 rise? So we're saying that if it is not more than 150, then it will not cause it to rise much. So on the exam, if they tell you that the patient has respiratory acidosis, they're on the ventilator, and they have respiratory acidosis, and the patient has a dead space of 8 now, not 150. First of all, you're going to say, well, the reason that their CO2 is rising is because they are rebreathing some CO2. So that would be the first thing you do. Did Mrs. Cathy teach you that? You correct dead space first. You remove dead space, no matter how small it is, you remove it fast. You don't have to wait until it's up to 150. Then if that doesn't work, then you think about increasing your tidal volume on your respiratory rate. Okay? Any questions about mechanical dead space? Dead space will cause your CO2 to rise. What it means is that you are breathing more CO2, and your true CO2 will go above 45. These are examples of dead space diseases. Pulmonary embolism. Remember now, dead space is ventilation in excess of perfusion. Well, pulmonary embolism, let's see how pulmonary embolism is a dead space disease here. A clot that has gone to the lungs. So I have a clot here, embolus. Blood can only perfuse this area, but it can't go past the clot. But my air is still coming in. I don't have any problem breathing in air, it's still coming in. But it's just that perfusion is decreased over here. So that makes it a dead space disease. Ventilation in excess of perfusion. Another example is pulmonary hypertension. Do you know that we have 4 different blood pressures in our body? Oh. But the only one that people talk about all the time is the systemic blood pressure, 120/80. Oh, what's your blood pressure? 110/70. Oh, that's pretty good. You got nice blood pressure. What's your blood pressure? 150/80. Oh, it's high. That's the only one we talk about. But we have 4 other pressures. You don't learn that in hemodynamics. We have the pulmonary blood pressure on the right-hand side, which is about 25/10. That's on the right side. The 120/80 is on the left side. That's systemic blood pressure. Okay? So actually, when your pressure on the left side goes above 120/80, we'll call that systemic hypertension. When it goes below it, we call it systemic hypotension. Here is the pulmonary blood pressure here. If it goes above it, we'll call it pulmonary hypertension. If it goes below, we call it pulmonary hypotension. So a lot of things can cause pressure on the left side to go up. One of those things is like a COPD, obstructive disease. They usually have pulmonary hypertension because they don't have enough oxygen, right? They have chronic hypoxemia. So now, hypoxemia inside the lungs will cause the pulmonary blood vessels to constrict. So, this is my heart here. That's my pulmonary artery coming out, like that. Now let's say that that's the diameter of the pulmonary artery now. And now I am hypoxemic. My pulmonary blood vessels will constrict. The diameter will reduce. So then, when it constricts this way, you have decreased blood flow to the lungs. Okay? You have decreased blood flow to the lungs. You're not perfusing the lungs as much. But you're still breathing in. So that's what makes it a dead space disease. So pulmonary hypertension is a dead space disease because it will cause the pulmonary vessels to constrict. COPD and pulmonary hypertension coexist. If you have end-stage COPD, more than likely you have pulmonary hypertension because they always have chronic hypoxemia. What's normal PaO2 for a COPD patient? 50 to 65, bingo, yeah, that's it, 50 to 65. But ours is 80 to 100. So that's enough oxygen for them, but it's not normal oxygenation. So because of that, their pulmonary blood vessels are always somehow constricted. That's how come, if you ever wondered why COPD patients will always be like on a couple of liters of oxygen, that's why. Oxygen is a vasodilator. Oxygen is a vasodilator. So that 1 or 2 liters of oxygen that they're wearing will always help to keep your pulmonary blood vessels a little open. Okay? So that's why we're doing that. Any questions about that? The next disease process that is dead space is CHF. Congestive heart failure. Congestive heart failure. One of my classmates really scared a patient one time at the hospital. And, I think that was our semester 2 in school. And she went, Mr. Smith, you got congestive heart failure, so we're going to treat you. So, and the patient said, what? I got what? My heart is congested. And the next thing we knew was she picked up the phone and called her husband. Honey, please come here to the hospital. This lady said my heart, I'm congested. I'm like, you are in trouble. Why did you tell her that? Never tell a patient what they got. Did you know that? You're not the doctor. Don't tell them what they have. Because you know, sometimes you wear a life jacket, you go in there, they don't know, sometimes they don't even know who's the doctor. Doc, am I going home today? You say, well, I'll be back, let me check and see. Then you go outside and call the real doctor. But if you go, well, yeah, I think you may be going home today, and then they don't go home today, when the real doctor comes, then you're a big lie. Okay, so don't tell them something that you're not supposed to be telling them. Now, congestive heart failure is a left-sided problem. When your left heart is weak, it's so weak that it cannot pump out blood to the body. So we're over here. So this is the aorta. And then we have the lungs here. So basically the way it works is the blood will flow from the pulmonary artery to the lungs. It picks up oxygen there, and then it will come back through the pulmonary vein, there's two of them, into the left atrium, and then it goes into the left ventricle before it goes to the aorta. Okay? So this is the left ventricle here. This guy is weak. That's congestive heart failure. Because the left ventricle is not strong enough to move blood into the aorta, it begins to back up where it came from. It's not back up here into the left atrium. It backs up into the pulmonary vein. It backs up into the lungs. So you may actually get pulmonary edema when your left heart is not working the way it's supposed to work. Okay? So now, if you have CHF, your blood pressure will be low. Because when you have reduced volume pumping out, your blood pressure goes down. So people with CHF that are not receiving any treatment will have low blood pressure. Low blood pressure. So you have reduced perfusion. When your blood pressure goes down, your perfusion goes down. Okay, so CHF is a dead space disease. And any other condition that will cause your blood pressure to decrease will be a dead space problem. Any questions? Well, how do we measure dead space? How do we measure dead space? Now, there is a PFT test called single breath nitrogen elimination test. That's one way to measure dead space. Single breath nitrogen elimination test. Like anytime we're breathing air, not only are we breathing in oxygen, we're also breathing in nitrogen. In fact, we're breathing more nitrogen than we're breathing oxygen. 78.9 concentration of nitrogen versus the 21%. But the only thing then is that that volume of nitrogen that we breathe in doesn't cross over and get into the blood. Oxygen does, but nitrogen doesn't. So nitrogen is responsible for FRC. That's what keeps the lung like this. That volume of nitrogen keeps the lung open like that. Okay? So that is what we're going to do. We're going to get out that nitrogen. Okay? And in that process, we're going to measure dead space volume. Okay, now let me tell you what the dead space volume is again. So this is the alveolus. So take this to be your break here. Dead space will be up here. Okay? And then the nitrogen will be here. So that's the dead space. So we want to measure this volume here. What's your dead space volume? We want to measure that. So the single break nitrogen elimination test, that's called the Fowler's method, is the most common method used in measuring anatomic dead space. Okay? What happens here is that the patient performs slow vital capacity. They take a deep breath all the way in, they are going to blow it all the way out, gradually by control. Okay? When they do that, they are going to first of all breathe in 100% oxygen. Okay? They breathe in 100% oxygen, and then the oxygen comes down here and mixes with the nitrogen, but they don't hold their breath. Okay? They don't hold their breath. Once they breathe in, they begin to exhale out. Okay? So what you're going to find out is that the first air that will come out from their lungs will be this here. This volume comes out. And it will be high in oxygen. You will have 100% oxygen. So this volume now comes out before the gas exchange volume begins to come up. And then if this begins to come up, nitrogen will begin to come out. Okay? So we measure the volume that has 100% oxygen in it. That will be my dead space there. Okay? And then it says the test is also used in measuring closing volume. Now, closing volume is something that they used to do in all the PFT labs many years ago. They don't do it anymore. I don't know of any PFT lab that still does closing volume. Closing volume is the amount of volume left in the lungs before the patient's airway begins to close. Because now you breathe in, your alveoli will open up like this, and then when you begin to exhale out, you will get to a point where the lungs will not close. That amount of volume in there before airway closure is closing volume. Okay? They used to use it a lot to diagnose obstructive pattern because they do air trapping. So they have more volume inside their lungs before the airway will close up. But some labs don't do it anymore. Okay? So now the amount of volume remaining in the lungs during the slow vital capacity test after the onset of airway closure while performing single breath elimination test. Closing volume determination is no longer done in most PFT labs. Don't worry about that, even for the exam, but we still teach it because they may use it to write a question just to get you confused. Closing volume is increased in obstructive disease due to early airway closure. Yeah, COPD patients, their airways are very floppy, not very rigid. So sometimes when they're exhaling out, they haven't completed their exhalation, then their airway will close up, trapping air with it. Okay, so that's why the closing volume will be increased in COPD, because they do a lot of air trapping. Okay? Do you know what autopeep is? Autopeep? What's autopeep? What's autopeep? Come on now, you just got two mechanical ventilation.
Isn't that?
Yeah, the pressure or the peep that you did not set. Okay? Air trapping. And I name is air trapping. Okay, COPD patients do a lot of air trapping because of their floppy airway. So what we actually do to fix it is we give them more PEEP. One way to treat air trapping is you give the patient what they are trapping to make their airway more rigid so that their airway will not close up before they have completed the exhalation. Okay, so this is the graph that is drawn on the screen when a patient is doing single breath nitrogen elimination test. Okay? So what we're doing here, measuring the dead space volume, so which is number one here. So this is the volume that will be exhaled first, right here. 100% oxygen. Okay? So about right here. Okay, so now, as the patient continues to exhale out, the nitrogen down here now will begin to come up. Now, what we're measuring is the nitrogen coming out now. So you will see a very sharp rise in the curve, meaning that nitrogen is beginning to come out now. So that would be phase 2 of the single breath nitrogen elimination graph, where the nitrogen and the mixture of oxygen is coming out. And then you go to phase 3, that is like a plateau, nothing but nitrogen and oxygen coming out. And then all of a sudden, the oxygen now, you have exhaled every bit of oxygen. And then you have another inflection point, changing direction, nitrogen. You're just now exhaling nitrogen, which is way down here. So there's a sharp rise in the graph, and that is closing volume. So phase 4 is closing volume. Okay? So the amount of volume in there before the airway begins to close up. Okay? For many years now, I haven't seen this on the exam, but sometimes they still use it to write the test. You know, you got to know what closing volume means. Okay? Any questions about that? So, phase 1, you're exhaling 100% oxygen. That's your dead space. Okay. That volume that comes out is what we're going to measure as your dead space volume before the nitrogen and the oxygen mixture begins to come out. Okay? And then we'll continue to phase 2. Phase 3 is plateau of oxygen and nitrogen mixture. And then you get to a point where there's no more oxygen being exhaled. You're just exhaling nitrogen. And then that will be a closing point. That is the point at which your airway is closing. Okay, we'll measure the volume. Okay? Any questions about single breath nitrogen elimination test? That's one way you can measure dead space. Okay? That's one more way to measure dead space, more method. Now this one here basically is that you're going to do a blood gas, you get your PCO2. And then you're going to have the patient exhale out. You get their PeO2. Okay? They will exhale out into the spirometer. You will collect the volume with the Douglas bag, and then the CO2 analyzer will analyze the amount of CO2 in that volume. That's your exhale CO2. And then we're going to use that PACO minus PICO divided by PACO. And we'll calculate dead space. Okay, so dead space again, the amount of volume that did not go down inside the alveolus. Dead space volume approximates patient's ideal body weight. Okay, so ideal body weight is calculated with height. When you're taking your body exam, if you want to determine what the normal range for a patient's standard one is, you're going to use the height, the patient's height. Okay, do that kind of thing there. But now sometimes if they don't give you the height, then you use your weight. Okay? But first of all, height. It increases directly with height and slightly with age. Normal is 20 to 40%. 20 to 40%. Now this is what that means here. So, let's say that I inspired 100 milliliter of volume. That's what I inspired, 100 milliliter. if I have 20 to 40% of it staying up here, then I'll be fine. That means that most of my volume went down here. So 20 to 40% of the inspired tidal volume, okay, staying up here is good. But if you have more than that, that's not good. You mean that not most of the volume went down here for gas exchange. Okay? Now, some books will say 25% is normal gas space, but that's fine. Yeah, let me tell you this. Do not be very rigid with your normal values. I'm going to tell you right now, okay? The numbers that we're giving to you are reference numbers. What is about normal? Because any textbook that you read will be a little different. And the MBLC knows that. Now, let's say that now I've told you that normal dead space is 40%. On the exam, if I'm given 41, I'll call it normal. If I'm given 42, I'll call it normal. If I'm given 39, I will come. You don't have to say, well, it must be 40. No, we don't do it like that. But now, if you get me 70, well, that's nowhere close to 40. That's abnormal, right? Or if you give me 10, well, that's completely off. So that's the way I want you to approach your normal values. Not what Kathy told you, or what I told you, or what Mrs. Polly told you. What you need to know is what is about normal. Okay? What is about? That's one thing I like about that board exam. If they want to make it abnormal, they will make it abnormal that no matter how stupid you are, you're going to know. You must know. Yeah, that's right. Now look at 40 and 80. Not even anywhere close. So you should be able to figure that out. All right. Okay, so move along now. We have another test called the ventilation perfusion lung scan, VQ scan. Now, this test here is good for diagnosing pulmonary embolism. Remember we said that pulmonary embolism is a gas-based disease. So somebody has blood clot, they're breathing like a freight train. We take them to nuclear medicine. Nuclear medicine is what they do this. Now what they're going to do is they're going to give you this compound here, xenon. It's an isotope, radioactive isotope. You breathe it. It can spread all over the lungs very quickly. They have you inhale it, and then it goes all over your lungs. And then they take a picture. They take X-ray to see how the xenon went all over your lungs. Okay, if you spread all over your lungs, all over, then that means that your ventilation is good. Okay? Ventilation perfusion scan. The next thing is perfusion. They will inject you with iodine. Inject you. And then the iodine will follow the vein, and then they will be monitoring it with X-ray to see whether it stops somewhere. And so it comes to the lungs, now it's flowing here, and it gets right here, it stops. It doesn't perfuse the rest of this area. So I got a problem right here. There's a clot here. That's why that iodine is not perfusing all over. So now I have decreased perfusion, but my ventilation is good because the xenon went all over the lung field. So ventilation is good, but perfusion is bad because the iodine did not perfuse the entire lung. So So that would mean that you have pulmonary embolism. So that's what VQ scan is. They take you to VQ scan, they do exactly that. They have your breathings in, they look at the X-ray, see how that will spread all over the lung field, and then they will inject you with that iodine and monitor the flow. Okay? We have something else that we call shunt, which is the opposite of dead space. Dead space is ventilation in excess of perfusion. Shunt is perfusion in excess of ventilation. So now let's say that the Xenon did not spread all over the lung field. That means that my ventilation is bad. But now the iodine perfused the whole lung. That means my perfusion is good. So what I have is a shunt disease, not a dead space disease. This test here will tell you that. What kind of diseases cause shunts? Well, all the seabirds, they don't breathe well. You got cystic fibrosis, bronchitis is bad, they don't breathe well. Okay? If you can't breathe well, you're gonna have shunts. Okay? My sister is calling me now. She's thinking maybe I got paid today. No, not yet. I get paid on Friday. That was bothering me. You know, my children know when I get paid, you know. And they know, can you imagine that? Every other Friday, my phone is ringing all day. And I don't pick it. Well, Daddy, why didn't you pick my call while I'm teaching? This is my excuse. Well, what did you want? Well, I want to see if I want to buy a shoe. This is my daughter who is an attorney now. She's asking me money to buy a shoe. I'm like, well, daughter, are you crazy? You make more money than I do and you want me to buy you shoes. All right. So, any questions about VQ scan? It's good for diagnosis of pulmonary embolism, but it's not the best test. It's not the best test. It's not always conclusive. Okay. When we get to the point where we are not really sure, there's another test called pulmonary angiograph. Pulmonary angiograph. That one is mainly injecting something into you and see whether it's going to perfuse, basically. And pulmonary embolism is flow problem. There is obstruction somewhere. The clot is obstructing something. So pulmonary angiograph is the best test. If you do VQ scan, if it's inconclusive, you do pulmonary angiograph. Okay? Okay, now, so let's go to diffusion capacity now. That's another key test. I tell you what, anytime somebody comes into the PFT lab, it's almost like they stay there the entire day. They will ask you to go for breakfast, and then you go to lunch, go for dinner, and you wonder, well, when am I going home because of all these tests? All right, so diffusion is like this. Here's the alveolus here. Here's the alveolar capillary membrane. And here's the blood. Now, there is something called life functions. Did you ever go over life functions? Ventilation, oxygenation, circulation, and perfusion. You have to have 4 of these things working all the time for you to stay alive. So, as a respiratory therapist, anytime one of the 4 life functions go bad, you have to react. Now look at this now. So we're breathing air into our lungs here. Well, that's not the end of it. You just got the oxygen down into your lungs. You're not done yet. The next thing now is for the oxygen to cross over here, AC membrane, into your blood. Now that's called respiration. Respiration and ventilation are not the same. You can ventilate well, but you are not respiring well. If you are not respiring well, your oxygen will be bad. So we'll get our oxygenation now into the blood. We're not done yet, because we need the oxygen down to the tissues. Now, this blood here needs to be pumped out from the left side now. It gets pumped out, it will circulate. The tissues are over here. We're not done yet. Okay? Now, this oxygen now being carried by this blood that is circulating has to get inside the tissues. You have to diffuse in here. And this is where we need the oxygen inside the tissues for metabolism to take place. So oxygen goes in, carbon dioxide resulting from this comes out, comes back here, and goes out this way. Okay. So now with diffusion, what we're doing then is your oxygen crossing over from here into your blood. Are you having problem, diffusion defect? Because if you're having diffusion defect, well, you're not going to get enough oxygen inside your blood. So that's what we're testing here. Okay? Diffusion defect. The ability of oxygen to cross over into your blood. Okay? It says that the test facilitates the diagnosis and management of most pulmonary disorders. And that is right. The gas used must be capable of diffusing across the AC membrane. Yes, we are trying to test and see whether there is any problem right here. Okay? And what we're going to do is we're going to use carbon monoxide. Because you know, carbon monoxide diffuses about 210 times faster than oxygen. So it's like, if carbon monoxide cannot cross here, the alveolar capillary membrane diffuse across here into your blood, well, you got a major problem. That's what we're doing. That's what we're calling the DLCO. Diffusion of the lungs with carbon monoxide. We're testing. Okay? The gas, in this case, the carbon monoxide must be capable of being transported by hemoglobin. Carbon monoxide is the most commonly used gas. Okay, because of that, its diffusion rate is proportional to this available surface area. Surface area improves diffusion. But if I have a long unit this way, and a long unit that way, this one here has got more surface area because gas can diffuse from all these areas. But now look at this one here. So, the more open you have the lungs, the more the diffusion rate, because you have more surface area. Okay? So, to summarize this, basically what they do is they mix up 0.3% carbon monoxide. Carbon monoxide is bad. Okay, so that's why we're using a little bit of it, just a little bit. Because if you bring in a lot of carbon monoxide, you're going to get hypoxic. Okay? It will quickly go and attach to the hemoglobin, prevents the oxygen from attaching, and now no oxygen will be transported to the tissues. Okay? And then you're going to die. Okay? If you want to kill somebody, You give them cyanide. No, I didn't say that. I didn't say that. You didn't hear it from me. It's the same thing. Yeah. All right. So you mix a little bit of carbon monoxide with 10% helium. You're going to have the patient breathing in, hold their breath for a while so that it can diffuse across, and then you have the patient exhale back out. Okay? So now what we're measuring is how much carbon dioxide actually crossed over into the blood. Okay? Because if you have carbon monoxide crossing over into the blood, well, then your diffusion is good. But you don't have a lot of it crossing over, while your diffusion is bad. Okay? So this is the formula that the machine uses to calculate the diffusion of carbon monoxide. So it says that the DLCO equals CO2 used minus CO2 returned plus CO2 remaining in the residues body. Okay? Here is what is normal here. 20 to 25 CO per minute per millimeter of mercury. That's normal. There's another way to express that. They can express that in percentage. If I divide 20 by 25, I get 80%. Remember I told you that all the pulmonary function tests, normal, is 80 to 100%. All of them. Any test that you're doing. So 20 divided by 25 is 80. 25 divided by 25 is 100%. So normal DLCO in percentage is 80 to 100%. Now they give it to you the other way, it would be 20 to 25. Okay?
I went to the PFT lab last Wednesday, and one of the patients there, her percentage was 24.
24.
24%.
Oh, 24, okay, that
Yeah.
would be very low.
It was like the RT. He said that he'd been in RT. He'd been working in a PFT lab for like 13 years, and he had never seen a DLCO that low.
Yeah. Do you know whether they have COPD?
I think it was COPD.
Okay, so
I know
one
she had
of them is
also.
emphysema, yeah.
Yeah, and I know she'd also gone into like a car accident some time ago that like really affected her lungs because she was intubated for a really long time.
Okay.
So it was like something like that where she was
Yeah,
just really
all of
messed
some
up.
kind of severe respiratory disease. So please memorize this number here. They can give it to you in CO per millimeter of mercury. And then if they really want to confuse you, they can put it in percent, a percentage. Okay? These are instances where the LCO will be increased. We're not really worried about what will cause it to increase. We're more worried about what will cause it to decrease. Okay? So left to right shunt will cause the DLCO to be increased. Indigenous people at high altitude, like people that live here in New Mexico, it will be increased. Exercise, left heart failure, supine body position, early polycythemia. What's polycythemia? Huh?
Red blood cells?
Yeah, they make more red blood cells, more hemoglobin, more hematocrit. Okay, if your red blood cells go up in number, your hemoglobin will go up in number. Your hematocrit will go up in number. Yeah, and anytime you have a patient that has polycythemia, hemoglobin that is greater than 16, suspect as COPD. Okay, COPD, obstructive disease. Because what happens is that because they have chronic hypoxemia, their pH is usually like 50 to 65, their oxygen carrying capacity is not good. So they make more hemoglobin. Their body responds to that hypoxemia by making more hemoglobin to increase oxygen carrying capacity to the tissues. Okay? All right. So these are the things that will cause the DLCO to decrease. Remember I told you that we are more interested in the thing that can cause it to decrease, okay? As far as the PFT is concerned. Now, if you look at this, you can say, well, the DLCO is mostly decreasing restrictive diseases. Emphysema is the only obstructive disease in which the DLCO is decreased. The only one. And it will be decreased because of decrease in surface area. Emphysema is the only obstructive disease in which the DLCO is decreased. So sometimes what they do on the exam is they will give you a PFT, okay, and then you make the diagnosis, you say, well, this is obstructive disease. And then when you go to your options, you see 4 obstructive diseases, right? You see 4 of them. You say, okay, well, I know that this is obstructive, and all of these are obstructive. But now you gotta look at one more thing. You look at that DLCO. If it is decreased, then you know that what you get is emphysema. Okay? Because emphysema is the only one. Any questions about that? Okay, so the next test now is measuring functional residual capacity. Remember, the A4C cannot be measured with simple spirometry. Take a deep breath, blow it out. No, that's not the way we measure A4C. It's a spatial test. 3 of them, 3 spatial tests. Now, A4C is the amount of volume left in the lungs at the end of normal exhalation. So if you breathe in, and then you breathe out normally, don't force it. Whatever volume left inside your lungs, that will be the sum of your ERV and your RV. That will be your functional residual capacity. Usually about 2,500 milliliter. Okay? Any capacity that has RV added to it cannot be measured with simple spirometry. So RV cannot be measured with simple spirometry. Functional residual capacity cannot be measured with that because it is ERV plus RV. Total lung capacity cannot be measured, okay, because it is ERV plus these other 3 volumes. So ERV, RV and any other volume, any other capacity that is part of, in which the RV is part of, cannot be measured. So now the first test to measure the functional residual capacity is the helium dilution test. Helium dilution test. Okay, so in this case here, what they do is they use a 10% helium. Okay, they mix it up with 600 milliliter of gas. Okay, and then tell the patient to put their mouth there on the mouthpiece. Okay, so they tell the patient to breathe in and out with their mouth on the mouthpiece. Okay, so they are going. They have something there that gets rid of the carbon dioxide that you're exhaling. They call it the CO2 absorbent. In that way, you're not exhaling, you're not breathing in a lot of CO2. There's a CO2 absorbent there that sucks out the carbon dioxide. So you put your mouth there, you're breathing helium in, helium out, helium in. And then at the point, you get to a point where the amount of helium inside your lungs will equilibrate the amount of helium inside the spirometer. Okay? It takes about 7 minutes to do that. That's how you're doing it. So now, once you've gotten to that point, this is the formula that will be used. Okay? I think the HE1 is the amount of helium before the test, and 2 is the amount of helium after the test. Okay, so that formula is what the computer will use to calculate your functional residual capacity. What's normal functional residual capacity? Huh? 2,500, very good, 2,500. test does not measure trapped air. It does not measure trapped air. So if you use helium dilution test to measure the F4C in somebody that has obstructive disease, it won't be correct. If they don't get trapping, that result will not be correct because it did not measure the trapped air. Okay? That's another one. Nitrogen washout. We have that nitrogen inside our lungs when we breathe in that is helping to keep the lungs open. We're going to breathe in 100% oxygen to wash it out. 100% oxygen will wash it out. We want to see how much nitrogen we get because that's our F4C. That is what maintains the F4C. So on this one here, the patient will breathe in 100% oxygen to wash out nitrogen from their lungs. Do you know that one of the complications of oxygen therapy is atelectasis? Do you know that? Yeah. Anytime a patient is breathing in oxygen that is greater than 60% in concentration, you can wash out some of their nitrogen, and then their lungs will go like that. So atelectasis is one of the complications of oxygen therapy. Okay? So that's how come if you're doing oxygen therapy, once you get to 60%, you stop. You'll be better off using PEEP to improve their oxygenation than continuing to use more FiO2. Now, it doesn't mean that you can never use 100%. There are times when you are not able to use PEEP because PEEP drops their blood pressure. And then you have no choice but to use 100% oxygen. But we like to get to 60, and then we stop, okay? We start giving them pressure. And then if we have problems, then we stop the pressure, continue with FiO2. But if we don't have problems, we can go to up to PEEP of 1,000, I don't care. Now look, let me tell you this. NBRC, these people call it NBRC, National Board for Respiratory Care. They will take you where no man has been before. I'm telling you the truth because now look, they can, on the exam they can say, well, increase PEEP to 40. Increase PEEP, P-E-P to 40. And then you're going, my God, PEEP, 40, their lungs are going to burst open. Now, the only guideline for giving PEEP is that you keep on increasing PEEP until you get the PaO2 that you're looking for, or you have a side effect. As long as you don't have any side effect, you can go to PEEP of 1,000. That is correct. Okay, so this is another test that doesn't measure trapped air. If you use this test to measure F4C in somebody that has COPD with air trapping, that will not be correct because it will not measure trapped air. Okay? And the last one is the body box. We have it in there, well, we took it out because it was taking a lot of space there. Now, the body box can measure trapped air. That is a good exam question here on the MBRC. A patient had their F4C measured with helium dilution test or nitrogen washout test. And then they turned around and had it measured with the body box. The result of the helium dilution test is 20. And the result obtained from the body box is 28. How would you account for the difference in results? Air trapping, very good. Because now, this box here was able to measure trapped air. This 8 here is a trapped air that this one here did not measure. Okay? That's a common question on the MBRC test. Okay. So now that body box, the whole patient is encased in there. So the patient is breathing in and out. We're measuring the pressure inside the box, plus the pressure inside the patient's lungs. And then we're comparing it to the volume inside the patient's lungs. The principle is based on Boyle's law. Boyle's law states that if the temperature is kept constant, as pressure increases, volume decreases. Or maybe as volume increases, pressure decreases. Pressure and volume are inversely related if temperature is kept constant. That's the principle. So the patient's airway pressure is being measured plus the pressure inside the box. Occasionally, there is what they call a shutter. Yeah, I have a shutter. The patient is breathing and sometimes that shutter closes the airway and then the patient is asked to pant, take tiny breaths. Like that. So actually, you're not breathing and inhaling inside the device. So that allows the accurate volume to be measured. Okay? You don't really have to know the specifics. All you have to know is that it works best for any COPD patient because it measures air trapping. Okay? And you can use it to measure TLC. If you want to measure your total lung capacity, you can use the body box to do that. If you want to measure your airway resistance in a patient, you can do that. If you want to measure your RV, you can do that. So a lot of things that the body box can measure. RV, FRC, airway resistance, and thoracic lung volume, which is the TLC. Any questions? Go to break. I just wanted to finish this lecture here. Okay, so body box measures or enables the calculation of the following. I just told you you can measure TLC with it, you can measure your RV with it, you can measure your airway resistance, you can measure your air force. Now here's another trick of the design. Like I told you here now, here's the Diffusion test 20. Here's the body box 28. How can you, or how will you account for the difference in results? They may not say air traffic. Sometimes they're not just that easy. They may say airway resistance. Would that work? Yeah. Airway resistance, because COPD patients have airway resistance. By the way, that's the reason why they crop air. Or sometimes they may go show you this and say, well, chronic bronchitis. Well, that's a COPD disease. That's a good answer. So if they go air trapping, you say, yeah, that is true. Emphysema or chronic bronchitis, you say, yeah, that is true. Increased airway resistance. You know why that's true as well. Okay? All right. Now let's take a break. And then we're going to go over interpretation here.